All right, coming to my subject, we have come a long way in treatment of glaucoma. I left in 1976, and the only thing we had was short stenometry, pilocarpine, and epinephrine, and the visual fields were on a tangent screen. Since then, we have gone a long way, but we are still frustrated in diagnosing and seeing the progression of the disease and the treatment. The glaucoma management, there are three elements as we know: the tonometry, checking the pressure, looking at the structure, now there are various machines to look at it, and looking at the function by the visual field. The tonometry has come a long way. We used to use Schiot's, now Goldman, which is pretty much a gold standard since 1957, but it's still not perfect, and it is only during the old study that we realized that central corneal thickness played a very big role. The new thing about the hysteresis with the Pascal dynamic contour tonometer came up in 2002. There are some clinics which are constantly using it, but again, it is not perfect. Another factor we have realized is that we are checking the pressure on a very short duration, and a diurnal variation plays a very big role. So in a clinical situation, we can do it is check the pressure at different times of the day, a kind of a modified diurnal variation, where the patient is not admitted and you are doing it on a single day. So the limitation of tonometry is measuring the pressure on a very short duration, every 3 to 4 months, and the patient is sitting supine. And as you know that there are all artifacts in this thing. The desirable thing, which is probably would happen, it has been introduced as a commercial IOP monitoring technique of putting a contact lens on the eye and you get a graph. This way you can get the pressure even during the sleep time or lying supine. It's non-invasive. There are other things which have been thought, and it has been presented that you can introduce a micro sensor into the eye with a 25 gauge needle, and this may be able to measure the intraocular pressure on a continuous basis. Now, these are not so practical right now, but definitely a micro sensor can be attached to a glaucoma implant and or intraocular lens, and this way you can measure the real intraocular pressure in the eye. As you know that lying supine, the pressure goes up both in normal as well as in the glaucoma patients, and it has been very much verified that the pressure at night during sleep is higher, and the drugs or the treatment should be directed more towards lowering the pressure during the sleep. Here another factor which comes into is the hypotension, systemic hypotension. So your perfusion pressures can be low. Your blood pressure goes down at night. We definitely are not using beta blockers during the evening time. And your intraocular pressure goes up. So the two things are reversed. All the studies have shown one thing, that lowering the intraocular pressure is the only thing and is beneficial. I mean, there are 7 of those studies. It has also been shown by the advanced glaucoma intervention study, if you can maintain the pressure of 18 on all the visits, you can keep the visual fields intact. So it is the lowering of the pressure and maintaining that lowered pressure is very important. So here it comes. You have to set your target pressure. As we know, more advanced the disease, lower should be the pressure. Younger the patient, again, you have to maintain lower pressures. And diurnal variation is important. Corneal thickness has become very important, and as we know, we all do corneal thicknesses in our glaucoma patients. And the last one, the compliance, which is very, very difficult, but it's very important in maintaining the intraocular pressure. Compliance, again, gets better if the patient is taught what they are heading with, what is the disease. I understand it is very difficult to convince a patient who does not have any symptoms to use drops or do the treatment to lower the intraocular pressure and get the side effects of those medications. The IOP, target IOP is set, and then you have to change it. It has to be individualized with each patient, because more advanced the disease, lower should be your target IOP. Looking at the structure, I'm sure everybody can say that this is a normal disc. It is not difficult to say with some RNFL defect. Here the RNFL defect is much more obvious. In notching, you can definitely say it is glaucomatous. But look at these two discs. I don't think so anyone can be very sure. There is little asymmetry, but there are central cups, visual fields normal, and pressure being normal, and as well as the OCT normal. Now what do you do with them? Now this becomes a difficult situation, and of course in high myopias with parapapillary atrophy, it is very difficult. So the structure, you have the structure, but again there is an individual variation, and sometimes it's not easy to assess. We have so many machines available now for OCT, and there are at least about 8 of them. We were able to do with the 12 micron, but now you can have 5 micron thickness measurement. So it has come a long way. Importance has been given to the central macular thickness with the GCC, the glaucoma complex. So we are not only looking at the retinal nerve fiber layer, but also the thickness in the macular area. But I just want to tell you that these are all machines which are good for progression of the disease, but to my mind the gold standard is still the photographs of the disc. And if you can keep those two photographs next to each other and see how the cupping has occurred, it is optic neuropathy. So optic neuropathy can only be compared by looking at them done at 2 different times, and to my mind that gives you the best results in telling whether disease is progressing or not. Coming to the function, the perimetry has come a long way. We have these automated perimeters where the Goldman was gone, and we know that we do the SAP, and there are newer softwares available for looking at the progression of the disease. Visual field index is a single number. It's important. It will tell you how much is the part of the normal left, and sometimes it can tell by single number, you can tell whether the progression is occurring or not. We know the summary tells you the rate of progression as well as event placed, whether there is a progression at some location or not. But as we know that these are all subjective tests, this is not uncommon to see in your practice. The visual field is good, goes down, becomes bad. So it is variable. The variability in visual field is very common, and you have to be very careful in telling the patient whether the patient has a disease or has progressed in his disease. To my mind, you need at least 3 visual fields to confirm whether the disease is progressing or not. By one field, you cannot decide whether the disease is there or it has progressed. The future may lie in electrophysiology with an objective, and multifocal VEP, a lot of work is being done. The problem is the probes are not good yet. We don't have a good way of recording it. So maybe the future would be that with the subjective part is taken away and multifocal VEP might become common. When it comes to treatment, the only thing we have is reducing the intraocular pressure. There are limitations with the medical treatment because of their side effects, and the surgical treatment also has its limitation because we are depending on the conjunctiva for this to work. And as you know that we get this frustration, the tubes as well as the trabeculectomies, and the newer techniques which are through the Schlemm's canal. The only problem is the resistance may be most of it in Schlemm's canal, but there is no procedure which is available to go beyond the Schlemm's canal. Everything is connected to the Schlemm's canal, and there may be disease which is beyond the Schlemm's canal and the collecting ducts, and that is why those are not working. They came one by one and they're falling apart. The medication, there are many of them. I don't want to go through that. You know all about that. The future is in the delivery of the medication. Right now you have to give those drops once a day or 3 times a day, and I think there is a keynote address by one of the speakers where the drugs are being given by either as implants or even as subconjunctival injection. Actually, there was a paper at the AGS where it is not commercially available, but it was from Singapore that they were giving subconjunctival Xalatan. So a biodegradable drug implant which will be good for several months, that would be the thing which probably is for the future. Sensor to monitor IOP, which I have done through development of artificial trabecular meshwork, which can be replaced and therefore be able to reduce the intraocular pressure. And in regenerative ophthalmology, from gene transfer to the dendritic expansion of the ganglion cells, these are all future things. We do not have anything about the neuroprotection and replacing of the ganglion cells. But there is a lot of work being done regarding these so-called the gene transfer studies, and I believe it may happen in our lifetime that we will be able to revive the ganglion cells. But anyway, right now, just for the treatment side, you have to set the target IOP. That's very important, and checking the corneal thickness. Monoocular drug trials just to see the effect. It is controversial. There are people who believe that monoocular drug trials are useless because there is passover of the drug to the other side. But I still believe to see if there are side effects or the patient is going to use them carefully. Closely monitor the disease progression. That's very important. As physician to a patient, it is very important for you to decide. The surgery is not simple, and surgery is not without complication. So my suggestion, or my one thing which message I want to give, is that you have to be very careful in seeing whether the disease is progressing or not, and you have to be careful in deciding the surgery. Keep in mind about drug compliance and adherence, because this is very difficult, and you can see it yourself. It is not easy to use the drugs which can cause side effects and the disease which does not have symptoms at all. The lastly, which I always tell the patient, is to block the nasolacrimal duct, and this is to prevent absorption, systemic absorption, and also the absorption of the drug into the eye is much better. Thank you very much for your attention.